Hi guys, this is Kristen Martinez. I am a licensed marriage and family therapist and I'm an expert in trauma-informed care. And today we're going to be talking about trauma. How do you know if it's trauma? Oh, I've had this issue come up over and over again as a supervisor, and I've worked a lot in community mental health agencies, and it keeps coming up. I will get assessments from children in the system, and they're diagnosed with dysregulated mood, they're diagnosed with oppositional defiant disorder, they're diagnosed with depression, anxiety, and my all-time favorite, ADHD. And this is going to be the first video in a series of videos that are going to talk about how do you know if it's trauma. And so I really want to set the foundation for trauma, what we think trauma is, what on all the different ways that it actually looks. So how is trauma defined in the DSM? And unfortunately, it's such a huge subject that, of course, the APA cannot fit all of the information about trauma into the diagnostic criteria or into the information about it. So whenever I'm coaching someone, I have to ask, what keeps them from giving a PTSD diagnosis when there's clearly a history of it? And it comes down to this really terrible vague description of what trauma is per the DSM, which is an experienced or witnessed event that threatens either harm or death. And so it's really vague because it really leaves it open to the clinician to interpret what exactly is a threat, what exactly could result in a trauma, right? And so you have to really, the DSM is expecting that you're leaning onto your knowledge and leading onto your understanding of the wider research involving in trauma, right? They're expecting that we are niched, that we have a specialty, and that a specialist is treating people, which unfortunately for you guys in community mental health agencies or those of you in groups, a lot of times aren't being given the opportunity to specialize in something, to niche in something. And so you're trying to gain information on all these different issues that you're dealing with rather than being able to really focus in on one particular thing. The reason that I chose to become niched in trauma, and I'm niched in a very specific kinds of trauma and things that trauma leads to. But because of my journey, I really have this wide base of knowledge in regards to trauma. The reason that I think it's so important is because we know through the ACEs study that almost 70% of the population can identify at least one major trauma. That's not even including bullying and other things that we know lead to trauma. Poverty, community violence, it doesn't even include those. It includes large events, separation, death, mental illness, abuse, neglect. Those are the things that the ACE study looks at. So if we can assume that at least 70% of the population has one major trauma, imagine how much of the population also includes some of that lesser trauma. So trauma is a huge factor in why people are stepping into your office and why they're having some difficulties in life. And that's why I'm passionate about it. And that's why I love it. So going on, I want to talk to you about why I think that the description in the DSM is vague and leads to people not being able to, sorry, my video went out. People not being able to diagnose PTSD when it is present. A lot of times we're asking a client if they remember having any trauma. Okay, that's our number one mistake. There's a couple of reasons that's a mistake. One is because a lot of times the people that we see, they don't even know what they've experienced is trauma. So first of all, we have to consider trauma as a type of jargon. We have to change our language around what trauma is. And when I say what trauma is, I call it toxic stress, because everybody understands what toxic stress is. And we know for a fact that toxic stress built up over periods of time leads to death, okay? So now, just with that information, we're not even making, almost any kind of stress can now qualify under that vague DSM diagnosis. So we need to make sure that when we're talking about toxic stress, we're getting the details, like what is making this stress that you had in your life, what made it so difficult, what made it toxic, what made it hard, harder than average stress. And that's what's gonna help us meet that very first criteria. Other things, reasons that people aren't gonna be able to talk about why they have trauma, or if they have trauma, is that some trauma happens pre-memory. Well, not pre-memory. We say pre-memory, but that's not really what it means. So any kind of trauma that happens either in utero or, I'm going to say 0 to 5, but it's really 0 to 3. That's trauma that's happening before something called your episodic memory kicks in. So around 3 years old, your episodic memory starts to go, and you kind of start remembering things in a more chronological order and events-based patterns. I remember my 5th birthday party and the things that happened at it, right? So you have that, you're able to create a story with the memory, and that's your episodic memory. Now, previously, people thought before episodic memory that things weren't actually stored in the memory, which is which research has shown us is totally not true. And what happens is that we have something called procedural memory. That's how we learn. That's how we learn to eat. That's how we learn to brush our teeth, how we learn to take a shower, what a bath is. That's how we learn a lot of things that we do is through something called procedural memory. And so highly stressful events that happen in utero, mother's illness, domestic violence while in the womb, things that happen to your mother between the ages of 0 to 3, so mental illness of your mother becoming ill, any kind of accident that happens to your mother is also affecting you as if you were your mother. And so those events, they don't get stored onto our episodic memory, they get stored into our procedural memory. And that's why a lot of times certain things can trigger people and you have no idea why, and they have no idea why. They just know in this particular situation, I kind of get tense, and it makes me, and I don't know why, I have no idea why. Or maybe a family member mentions like, oh, well, when you were 2, we had this big car accident and it was really terrible. And maybe that's why they're nervous around cars or certain smells. It's really hard to tell. So getting a really good history of that 0 to 5 can really be helpful, and encouraging clients who come into your room who don't have knowledge of 0 to 5 to figure it out, to get in touch or sign a release for you to talk to family members, to doctors, to go back into medical charts and try and figure out like what happened during this time. Encouraging them to talk to their mothers, fathers, siblings, like what was mom's pregnancy like? Not even that, but what was mom's life like at that time? How stressful was it? It's really important that we start to look at those events from not just the developmental perspective, but also from the trauma lens perspective. So anything that was traumatic, I don't want to say traumatic, that was highly charged emotionally or physically is going to imprint onto the procedural memory and can still, even though they don't have an episodic memory of it, result in the symptoms of post-traumatic stress disorder. So those are a lot of the cases where people are like, well, I can't diagnose PTSD because they're not saying they have trauma. But at the same time, if they have if they're meeting most of the criteria for PTSD, at some level, we have all the red flags, and we really need to do some digging to find out where the root cause is coming from. So if you move past, that's my 0 to 5 in utero kind of trauma, right? And a lot of us have it. A lot of times when, and I want to say, a lot of times what they found is if somebody's getting a lot of like stomach related pain or somatic symptoms regarding their gas, like IBS kind of stuff, a lot of times that's actually related to the early birth trauma. So in utero trauma and 0 to 3 kind of traumas, if they're having a lot of somatic symptoms, I would suggest that you do a lot more assessment around what happened in utero and 0 to 3 stages of life. So if you look past, let's even get past that. Okay, we're done with our early developmental kind of trauma. That's one of the things. I haven't even talked about attachment trauma, which you rarely, nobody has a memory of attachment trauma. It just happens. It happens in that period when it's like procedural memory. Our attachment is formed before our memory even, our episodic memory kicks in. So that's also the time to be looking at attachment. Like, was mom sick? Was she in the hospital? Was the child, what was the client hospitalized? Were they in NICU? Did they have surgeries? Was there anything going on that could have affected the attachment between the child and their caregiver? And was anybody able to step in and provide a secondary attachment versus the primary attachment? I know trust me, guys, this is just one little blip of what trauma is and what's contained into it. And I hope you follow me, subscribe to my channel, because I guarantee the more you follow me, the more you'll feel confident in working with trauma and diagnosing it. And eventually we'll get into interventions too. Okay, so then I want to talk about something called transgenerational trauma, which I'll link to the video in which I talked about it below. But that's kind of like this idea that both genetically and nurture-wise, we pass down trauma through generations. And I'll link to that. It also leads to a whole lot of other things. If you guys look, post-traumatic slave syndrome, all of that is kind of based on transgenerational trauma. And we know through research of how toxic stress actually changes genetics and passes through generations. Fascinating, guys. I'll link down to the video in the description. So past transgenerational trauma, I know there's so much to talk about. Past transgenerational trauma, I want to talk about like somatization. So a lot of times clients come in and they're complaining somatically of issues going on. And a lot of times, because this happens a lot with our clients who have experienced chronic and complex trauma. Oh, which, by the way, I'm going to have a freebie. I'll link to it down below. Yes, I'm going to ask for your email address in exchange, but I'll have all of the definitions of the words and jargon that I'm using down below in this freebie. So please sign up, get this freebie, use it, give it to people. I don't care. I'm really passionate about just getting quality care out there for people with trauma. Okay, somatization. So a lot of people get diagnosed with somatization disorder, which is like where our anxiety gets stored into the body. And so we have a lot of bodily issues that can't actually be explained by doctors. And doctors usually refer to therapists. So a lot of times you'll get people who have chronic or complex trauma, which means like things like community violence, things like poverty. Let's take a refugee who's born into like a war-torn place and then are removed from that and then placed somewhere like the United States where it's not so traumatic every day. And what you'll find is that people will tell you there's no trauma, there's nothing that was stressful happening because they were born into it. And they've already had like genetic changes. So they're unaware of the change and how their system has been affected. And so what you'll find more and more with them, because it's like a regular thing, like trauma is just the norm, is that you'll find a lot of somatic issues, a lot of health problems, a lot of body symptoms. And so we really need to look at our clients who are coming in with a lot of health problems, with a lot of somatic complaints. We need to look at where they came from. Like, are they moved? Is there an immigration history? We also want to look family history wise. What does the family's history look like, especially in regards to like that just chronic trauma, especially is there a Holocaust survivor, or was the family, did they experience World War II? Are they coming from Central America where there's so much, it's just war torn, it's just the expectation. So we really need to start exploring not just the client, but also their history, like the historical trauma that has happened for them. Are they coming from somewhere like Rwanda, where there was genocide? Like, we have to start taking those things into consideration. We need to look at our clients who are from less privileged groups. We need to ask them their experience and their history. How far back can they go? Was slavery an issue for their family? Is oppression, systemic oppression, an issue? Because systemic oppression is absolutely 100% traumatic. And we need to start also using that in our diagnosing when we see somebody who's experiencing systemic oppression, and we need to be able to say like, look, this is causing this stress, and these are the symptoms that are coming out of it, which meets criteria for post-traumatic stress disorder. Almost every single time I've seen it, it comes and meets criterion. It's just you're not seeing the red flags, and you're not seeing how to diagnose it, and that's why it's getting missed. No big deal, because I'm going to be with you guys on how to do this and how to get this stuff diagnosed. Oh, I love this, and I came up with it. But I want to put out there that what trauma is, it's toxic stress, right? Toxic stress, and it's made up of really highly emotionally charged events. I don't even want to say emotionally charged. Like, there's a lot of energy in these events, or there's small amounts of negative energy over long periods of time. And it's okay, like not everybody recognizes what they've gone through as traumatic or toxic. Not everybody recognizes it. Not all of your clients will agree with you that what they went through is traumatic. However, someone can still have post-traumatic stress disorder even if they deny the event as something that affects them. I'll say that again. Not everybody recognizes their experience as traumatic because it might be the norm. It could be seen as everybody goes through this. That is not, you do not have to take that into consideration when you're making the PTSD diagnosis. Someone can still have post-traumatic stress disorder and trauma responses despite denying a highly charged event as affecting them. So when you're going through and you're asking your clients if they have trauma and they say no, and then they come up and they say, oh yeah, this thing happened, but it never really affected me. That does not discharge you from assessing for post-traumatic stress disorder. Because even though they see the event as not affecting them, that may not be the case. And it's our job to distinguish whether or not that event has actually affected them. And we do that by going through and diagnosing each individual criteria of post-traumatic stress disorder. Again, in future videos, we're going to get to it. We're going to break down each and every criteria of post-traumatic stress disorder, how to assess for it, and how to make that diagnosis in the end, which I think is preventing so many people from getting valuable services that they really need. And it's also preventing clinicians from giving the correct kinds of interventions to people. Okay, so like I said, I just want to hammer this home. Is asking someone if they have trauma is not assessing for trauma. That is not how we do it. Trauma is diagnosed through the exploration of the inner process of a person. And I'm going to teach you how to do this. I can teach you how to do a rough assessment of trauma in less than a week, which will meet most criteria for the agencies that you work at. I did it on a regular basis. I assess trauma constantly. And I'm an expert at it. And I can teach you how to do it. Okay, and then also, like I said, I'm going to be doing lots of these trainings for you guys to look at how to look at the criteria of PTSD and to really shift your perspective from the veteran example of post-traumatic stress disorder into the idea of more of the complex trauma examples that we see more on the day-to-day basis. But if you work with veterans, PTSD is obviously a huge issue. So that's some of the stuff that we are talking about in today's example. I really hope that you are able to take some of the information that we talked about today and take it into your practice. Like I said, the big thing is when we're going through criteria, we're looking at the DSM, it's really vague and it's really easy to meet that criteria. You just have to know how to meet it. You need to know the research that would support your diagnosis. Again, the freebie on the bottom, where I'm going to include a lot of definitions of things that are commonly tossed around in the trauma-informed world, things like acute trauma, chronic trauma, complex trauma, vicarious trauma, compassion fatigue, transgenerational trauma, threat responses, re-traumatizations, and triggers. And then I'm going to give a couple of examples in that freebie, how I talk to families about trauma and how I change the language around trauma to make it more palatable to them and less stigmatizing. And then also I put some resources for some great organizations and some great articles about post-traumatic stress and trauma. So thank you guys. I'm going to link below, sign up for my freebie, and then also link to any articles or videos that I have on any of the topics. Thanks, guys, and have a great rest of your Thursday.